Let's look here at our arterial blood pressure. This is basically the pressure that's in our aorta mainly. This is going to vary throughout the cardiac cycle. We talked about this last semester. Our highest reading at systole is going to be the systolic blood pressure. That's the maximum pressure that we see in the aorta at the end of systole. This is when blood is being ejected from the left ventricle into the aorta. And then our lowest reading across the cardiac cycle will be the diastolic blood pressure. This is going to be basically at the end of diastole, where we have the valves being closed because the ventricle is filling, but the blood is moving away through the aorta. And so we've got the lowest pressure recordings in the aorta at this time during diastole. So systolic, highest blood pressure in the aorta, diastolic, lowest blood pressure in the aorta. Now, the pressure in the aorta during diastole is usually low, but it's never zero. And the reason that it's never zero is because of that elastic recoil of the artery, right? I really want to make this point or drive this point home, that because we see the arteries, the aorta specifically, expand to absorb some of that pressure, right? Remember, it's highly elastic, but then during diastole, as blood moves away throughout the systemic circulation and the valves are closed, the aortic valve is now closed, in order to maintain flow, that aorta is now going to recoil on itself. And so that is going to generate some pressure. So whereas during diastole, we see the pressure being low, it's never zero because the pressure stored in the wall is now recoiling and exerting some additional pressure to keep flow constant. All right, we're going to move now to speak about blood pressure. So how do we measure blood pressure and how do we use those measurements to tell us about the state of our arteries? And so I'm sure we've all been to the doctor, we've all had our blood pressure taken. I think most of you are CNAs, and so I'm sure you've also taken blood pressures and are familiar with this process. So essentially we've got this sphygmomanometer. It's a really difficult word to say, which is basically our blood pressure cuff. And we simply use it to compress arteries, usually our brachial artery, right? So it's usually in the left arm. We compress the brachial artery and we listen for any turbulence in flow. Now, turbulence in flow is called Korsakoff sounds. And these Korsakoff sounds are going to be an indicator to us about whether or not blood is flowing through the vessel and whether or not the vessel is fully patent, fully open, or if it's slightly compressed and we're hearing that turbulence. And so when we hear that turbulence, that's going to be an indicator that we're now observing our highest blood pressure, which is our systolic blood pressure. So the first Korsakoff sound that we hear is synonymous with, or is going to be indicating the systolic blood pressure, the highest reading. Then we're going to uncompress the artery. And now we're going to listen for laminar flow. And laminar flow is smooth flow. This is when blood is flowing through a fully open, fully patent vessel. And so we hear absolutely no sound, no turbulence. And so when we hear that, we're then going to observe or record our lowest pressure in the vessel, which is going to be our diastolic pressure. Okay, and that'll make a little bit more sense on this next slide with these drawings here. So let's explain this here one more time. So we've got blood flowing through our brachial artery, which is the artery that we usually observe blood pressure in. We're going to put on that sphygmomanometer. We're going to compress the vessel, compress that brachial artery. And in the same time, we're actually listening with our stethoscope to observe any turbulence in flow in that vessel. And so we're going to inflate our blood pressure cuff to exert external pressure on that artery. Remember, we're trying to compress the artery. And so we're measuring how much pressure we're exerting on the artery, because if the flow can overcome the pressure that we're exerting, we can measure how much pressure is actually flowing, that blood is actually flowing under, okay? Let me say that in another way. The blood in the vessel will only overcome the compression that we're putting if the amount of pressure in that artery is higher than the amount of pressure that we're exerting externally using the cuff. And so we put the cuff on, we inflate it to above 110 millimeters of mercury, which is usually the higher parameters of our readings. And then we slowly start deflating the cuff. So we slowly start deflating the cuff until we hear turbulence of flow, right? So we're also listening for turbulence of flow. So as we deflate that blood pressure cuff and we get to the first bit of turbulence, that's going to be our systolic reading. So when we start to hear these cough sounds, that's telling us that the pressure in the vessel, the pressure that the blood is flowing with, has now exceeded the pressure that we are exerting externally with the cuff. And so we can record that as our highest reading. That's going to be our systolic blood pressure. We're going to continue to release the pressure in the cuff, right? Releasing it gradually until we no longer hear these cough sounds. That's going to be our diastolic pressure, right? Remember, when blood has now continued flowing laminarly, right? This laminar flow where there's no longer any compression or interruption or turbulence, this is where the vessel is now fully patent and fully open. And so the sounds should disappear. That's going to be observed as our lowest reading or our diastolic pressure. And so the systolic pressure is going to be when the sounds appear at first, and then the diastolic pressure is going to be when the sounds end or disappear, right? Turbulent flow, and then that laminar flow. Okay. Let me pause here and see what questions we have about this. Okay. Let's keep going here. Now, so what we typically get is our systolic pressure, our diastolic pressure, which is usually expressed as a fraction. So that 110/70 is systolic over diastolic. And that can tell us a lot about, the state of our vessels, how much pressure our system is exerting. It can also tell us about the state of the left ventricle, right? If the left ventricle is working really hard, we're going to see higher pressures in the artery. So that's going to be a really helpful clinical number. That's why your doctor takes that blood pressure every time you go for a visit, right? It's going to be really important as far as the health of your vessels, the health of your vasculature, and then the health of your heart. Other interpretations of our systolic and diastolic pressure is the pulse pressure. And the pulse pressure is simply systolic pressure minus diastolic pressure. And what this value tells us is how stiff or how rigid the aorta is, how stiff or rigid the arteries are in general. And if you think about the calculation here, a pulse pressure of about 40 millimeters of mercury, which is kind of standard, is a systolic pressure of 110 minus a diastolic pressure of 70. And so if we think about this and we think about a really stiff artery, a stiff artery is not going to recoil as well as we would like. And so what we'll see is that the diastolic pressure would be much low. Remember, we said that during diastole, what keeps the pressure maintained is the recoil of that artery. And so if we have a really stiff artery, it's not going to recoil as well during diastole. And so we're going to get lower diastolic readings. Let's say this was about 20. And so when we measure our pulse pressure with a diastolic pressure of 20, it's going to be a really high number, right? It's going to be about 90 millimeters of mercury. And so that's going to tell us the higher our pulse pressure, the more stiff our arteries are, right? The less recoil, the less elasticity that those arteries have. And so the pulse pressure is another meaningful number as far as telling us about the givability, the elasticity, or the stiffness of our arteries. And then another interpretation here is the mean arterial pressure. We've talked about this value earlier. We talked about it being an expression of our driving force, an expression of our pressure gradient. And so one way that we can calculate this value using our systolic and diastolic pressures is this formula here. So the systolic pressure plus 2 times the diastolic pressure divided by 3. And that usually gives us a reading of about 83 millimeters of mercury as our mean arterial pressure. Now, I don't want you to be confused. We talked about another way of deriving this mean arterial pressure, right? Remember, if you remember, we talked about mean arterial pressure minus central venous pressure, and we also arrive at this very same value, about 83 millimeters of mercury, if we take that 85 and subtract 2 millimeters of mercury, all right? So 2 different ways to derive or to arrive at the same value. Now, I want us to think about why we calculate the mean arterial pressure this way. So we use the systolic pressure, and then we use 2 times the diastolic pressure. Now, can anyone think about why we actually multiply diastolic pressure by 2? If we're thinking about the average pressure in the aorta throughout the entire cardiac cycle, why do we take systolic pressure into account once, but diastolic pressure into account twice?
Does diastole take longer?
Excellent. Yes, thank you. Excellent. So diastole is actually much longer than systole. In other words, the heart spends more time filling than it does ejecting. And so as we look at the average pressure throughout the entire cardiac cycle, we're going to take systole into account once, but diastole into account twice. Okay. Just kind of explaining how we get that, that calculation there. Okay. We'll wrap up here by looking at a few of these checkpoint questions. And we'll call it a day for today. So the first question here, name the 3 types of tissues commonly found in a blood vessel. So what are the 3 tissues that we talked about that we see in our vessels in different proportions across different branches, but they're all 3 present in our vessels? Yep, so we got smooth muscle, excellent, yep. What are the other 2 tissues? So not cardiac muscle, the other 2 are connective tissue, right? But more specifically, 2 types of connective tissue. So endothelial cells are present, but we're talking more about the outside wall of the tissues. Excellent, so fibrous tissue and elastic tissue, perfect. So they're both connective tissue. Fibrous tissue, we said, is gonna give more of that tensile strength, right? That toughness, if you will, to the vessel so that it can resist any shearing from the pressures. And then elastic tissue is gonna give that, that givability, that elasticity. And then smooth muscle is the third tissue type. Let's look at the second part of the question. Define compliance. How does compliance of arteries contribute to their function as a pressure reservoir? So first of all, what is compliance? And then how does this compliance in arteries contribute to their function as a pressure reservoir? All right, so excellent. So compliance equals the obedience or the ability to stretch and stay stretched. Good, so that is what compliance is. It's the obedience of the vessel, the ability of the vessel to stay where you put it, if you will, to accommodate more volume. And we said that arteries have less resistance, right? Excuse me, less compliance. They're very low in compliance. And so that low compliance that we see in arteries is what gives them the ability to stretch when we've got blood flowing during systole. And because they're not compliant, they're not obedient, they're going to recoil when blood is no longer flowing during diastole. And that pressure reservoir ability of our arteries is required to keep flow constant during systole as well as diastole. Okay, excellent. All right. So someone's asking to repeat the answer for question 1. So the 3 types of tissues that are found in a blood vessel, we said it's got smooth muscle lining the wall, it's got fibrous connective tissue, it's got elastic connective tissue, right? It's also got the lining, which you talked about, which is endothelial cells as well, okay?